Thanks very much, Monique, and thank you everyone for attending the Speaker Series presentation this morning. Before I start, I'll just let people know that these slides and a recording of the presentation will be available, not directly after the presentation, but probably within a week or so. So you don't have to scroll down notes and stuff. As I said, there will be a recording and the slides will be made available to everyone following the presentation. So let's start with the conclusions for those of you who pushed for time. So there's going to be 3 take-home messages for today. One is that there are imbalances across every area of the return to work process for claimants who have psychological injuries compared to those with musculoskeletal conditions. And we'll go through each of the different areas as I go through the presentation. But to say that there's not going to be a single thing that is going to be key to improving return to work outcomes for people with psychological conditions, but it's going to be a large set of things that need to be addressed. The second take-home message for today is that modifiable factors, in particular the supervisor response and having a return to work plan that is consultative and correctly modifies duties in the workplace, as well as targeting symptoms of mental health conditions, explain 2/3 of the difference in return to work between psychological injuries and musculoskeletal conditions in our cohort. And the third take-home message is that differences in sustainable return to work or the duration of wage replacement between psychological conditions and musculoskeletal conditions can be modified. So while treating symptoms of mental health conditions remains an important thing to do, creating a workplace context where supervisor responses to these conditions can be more supportive and return to work plans can be more consultative are also just as important in terms of improving return to work outcomes for people with work-related psychological injuries. Now, in Ontario, as of January, the start of January 2018, chronic mental health stress claims have now been included as part of the workers' compensation setting. In the cohort in Australia that I'll be talking about, which is in the state of Victoria, these types of conditions have been compensable for over 2 decades. So the findings which I'll be providing today do give us some insights into what could be happening or will be happening within the Ontario context now that these types of injuries are being accepted for workers' compensation. In terms of psychological injuries in the Australian context, we know that these types of conditions are both increasing. They've been steadily increasing since about the year 2000. And we also know that they are associated with greater wage replacement and healthcare costs following the injury. So this is some information from Safe Work Australia, published in 2013, which looks at the median weeks of wage replacement for psychological injury claims, which are the red bars, compared to all claims, which is the blue bar. And on the right-hand side of this picture is the median healthcare costs and psychological claims, which are the red bar, and all claims, which are the blue bars. And you can see in each of these situations, psychological claims have somewhere between 6 and 10 times the wage replacement and healthcare costs compared to all other types of injuries. So the study which I'll be presenting today is called the Monash Return to Work Cohort Study. The objectives of this study was to understand the return to work process among workers' compensation claimants in the state of Victoria in Australia. The cohort was designed specifically, the sampling was so that we could understand differences in the return to work process for psychological claims compared to musculoskeletal injuries and for older workers compared to younger workers. So this cohort was set up at a time point in Australia where most of what we knew about what worked in return to work was for musculoskeletal conditions. So most cohorts of workers' compensation claimants have actually tended to focus on musculoskeletal injuries because these are the most common types of injuries within the workers' compensation systems. And most of what we know about mental health has been generated from European countries where there isn't a distinction between whether the condition is work-related versus non-work-related. And so I guess at that time in Victoria, we didn't know whether we could generalise work coming out of Europe among a sort of an all-cause section of psychological conditions. Could we generalise that to work-related conditions? we know from other types of conditions that we can't simply, when something happens in the workplace, it's a different context to when something happens outside of the workplace. And so part of this was to address those two information gaps. One, that we didn't know a lot about psychological work-related injuries, and what we did know about mental health conditions was generated predominantly from jurisdictions where there isn't a distinction between whether the condition is work-related or not. This baseline sample was recruited over a 12-month period between June 2014 and July 2015. So just to tell you a little bit about the Victorian context, WorkSafe Victoria covers about 80% of the labour market in Victoria, so a little bit higher than the coverage here in Ontario. The first 10 days of incapacity are paid for by the employer, so it is different to the Canadian context in that situation, where in most Canadian jurisdictions, the system pays from day one, the first day after the day of injury. Mental and physical injury claims are eligible for compensation, as I sort of alluded to at the start, and have been for more than 2 decades. One of the other key differences in the Victorian system is that the management of workers' compensation claims is performed by 5 external claims agents. So it's not handled by WorkSafe Victoria, but there are 5 external companies which handle the adjudication and the return to work process from the system's perspective. All large workplaces are required to have a coordinator at all times, and smaller workplaces must appoint a return to work coordinator if an employee is injured. And in Victoria, there's also this second system where workers' compensation claimants can go through a common law system for injuries that are deemed to be very serious, or after a certain length of compensation for pain and suffering. So it is slightly different, that it's not a complete no-fault system like we have here in Ontario. Just to describe the cohort, which is in a paper which has been published in BMJ Open, the initial recruitment of the cohort, so the baseline interview, took place at about 3 to 4 months post-injury. And there are various reasons for that around the adjudication, the 10 days of wage replacement, the adjudication, and the recruitment of the cohort, around how we sent out the primary approach letters and then had to wait a certain amount of time for people to opt out if they wanted to. We then did a first follow-up interview at 6 months following the baseline, which is about 9 to 10 months post-injury, and then a second follow-up interview 12 months after the baseline cohort, which is 15 to 16 months post-injury. You can see the number of participants who participated at each of the time points, which are the dark blue boxes. The main reason for non-participation at each time point was just that we couldn't get in contact with people. The Dimitriadis paper in BMJ Open talks about the sample in terms of the original sample recruited, which was generally representative of the source population, and then non-response, which was mainly related to being younger in terms of, and male in terms of non-response over time. In terms of, I will be presenting very limited information on the linked data today, but just to let you know, in terms of this cohort, we do have access to linked data. So the survey responses, 91% of respondents gave permission for us to link their survey responses to the different data sets that are available within the workers' compensation system, which includes hospital admissions, different services, payments, medical certificates. And so we do have an extended follow-up on claimants. Current linkages to the end of December 2018, but it can be updated at any time. And so it does allow us to follow the respondents and also understand the administrative information, how it moves over time. Although, as I said, I'll be presenting limited information on that today. So I won't be spending a lot of time on the methods, although I'm certainly happy to take questions on the methods. Just to give you a quick overview in terms of interpreting results, I'll either be presenting them as just prevalence estimates, so just bar graphs, or I'll be presenting them as interquartile ranges. And this is an example of an interquartile range on the right-hand side of this slide. So there's usually 2 boxes. The bottom of the grey box represents where the 25th percentile of the distribution. You can imagine most of the time we see distributions that look kind of like a bell curve. Often with wage replacement, we tend to find there's a skew. So the blue box is often bigger than the grey box, which indicates there's a bit of a skew to the right-hand side. Where the boxes meet is the median. So that tells us 50% of the people are below that point and 50% of the people are above that point. And the top of the blue box tells us where the 75th percentile is, so where 75% of the distribution are below or 25% of the distribution are above. And the bottom of the grey box tells us where the 25th percentile is, which is 25% of the distribution are below that. Almost all estimates, except for the one I'm going to present on the next slide, are adjusted for potential confounders, which I'll describe later. These are factors that might be associated with injury type, might be associated with whether someone's returned to work or not, but aren't a consequence of the injury type. So this just gives you an overview of the return to work at each of our different time points on the left, both for the psychological injuries, which are the blue bars, the musculoskeletal conditions, which are the orangey bars, and the entire cohort, which is the grey bars, and also the duration of wage replacement over the first 2 years. Again, these are these interquartile ranges. You can see that for psychological conditions, if we focus on the wage replacement, at the median had 21.5 weeks of wage replacement compared to 12 weeks among the musculoskeletal conditions. So the differences that we expected from psychological conditions to have longer durations of wage replacement were also present in our particular cohort. And again, in both situations, our blue boxes are a little bit bigger than our grey boxes, which shows that there is a skew in the distribution, which is we expect often with wage replacement. In terms of sustained return to work, which is our left, which is on the left-hand side of this, you can see that there are quite large differences at time one between psychological conditions and musculoskeletal conditions in terms of the proportion of people who have returned to work. A sustained return to work, we've defined that as they've been back at work for at least 28 days. So you can see there are quite large differences of about 17% at time one. Smaller differences, but still around 14% at time two. And by time three, the differences are about 6%. They're no longer statistically significant at that time point. You can see that while psychological conditions tend to, the return to work rates increase over time, among our musculoskeletal conditions, we see there is certainly a plateau which occurs between time two and time three, which is, again, this is 9 to 10 months post-injury to about 15 to 16 months post-injury. So the focus for today is what we're going to be looking at is injury type. So whether something's a psychological conditions versus a musculoskeletal condition, and how that's related to both important predictors of return to work and also return to work outcomes. In terms of grouping the important predictors of return to work, we're going to use this diagram by Wazell, published in 2005, which sort of describes areas in the return to work in four main areas. One, if the bottom of this figure is around the person, so personal coping, personal system. On the left-hand side, around the healthcare system. On the top of the figure is around the workplace system. And then on the right-hand side of the figure is around sort of the insurance system, the legislative and insurance system. And I'm going to group the factors that I described to you within these four large buckets in line with the Wazell framework, or the Wazell diagram around the workers' compensation context. So these are the potential pathways between injury type and return to work. So at the personal level, we looked at self-reported mental health symptoms. This is on a scale of 0 to 24. I should say at this point, what we wanted to do, because we're looking at sustained return to work, for each of these factors, we framed them in a positive light. So a higher score on self-reported mental health symptoms indicates an absence of mental health symptoms. So higher scores are better. Positive recovery expectations was the second factor we included at the personal level. At the workplace level, we included 4 different factors. One was a supervisor reaction to injury, whether that was positive or not. The second was the co-worker response to injury, whether that was positive or not. And this wasn't the worker's perception of whether it was positive, but both the supervisor and the worker, they told us about how they responded to the injury. You know, were they concerned? Did they want them to put in a workers' compensation claim? Did they want them to not? Did they believe them? And we grouped these as whether they were positive or negative, or not positive, I should say. Return to work coordinator interaction. So this is at the workplace. As I mentioned at the start, all workplaces are required to have a return to work coordinator. And we asked people whether those interactions were stressful or not stressful, or whether they had no contact with their return to work coordinator. We asked about a return to work plan and modified duties. These two areas were actually quite related to each other, so we used a 3-level variable to group the responses. So the first level, the most positive, was where there was a consultative return to work plan and an offer of modified duties that occurred. At the second level was where there was an offer of modified duties, but the respondents said they weren't consulted about the modified duties. And at the third level was there was no return to work plan and no offer of modified duties given to the worker. At the healthcare provider level, we looked at if the healthcare provider had given the respondent a date that they would likely return to work, and if they'd had contact with the employer or the occupational rehabilitation provider. And at the system level, we asked about 2 factors. One was about whether the respondent agreed that their claims agent, so this is now at the system, so these are the 5 different organisations that adjudicate and manage workers' compensation claims for WorkSafe in Victoria, whether they agreed that the claims agent was polite, treated them with dignity and respect, provided information to them at the right times, was open and truthful, that they explained the return to work process, they communicated appropriately, and that they considered the claimant's specific needs. And then we also asked them if the interactions with their claims agent were stressful or not stressful. In terms of the confounders, so these are the things that I spoke about before around that might be associated with the type of injury and return to work, but are not a consequence. So we want to take these into account when we're looking at differences in injury type. And from here on in, every estimate I give you has been adjusted for each of these different factors. So we looked at age and the sex of the respondent, if they had any activity limitations before they got injured, the physical demands of their work environment pre-injury, the amount of job autonomy they had pre-injury. So we know that job autonomy is associated with both with psychological conditions, but also it can help people return to work if you can provide them with autonomy. So we adjusted for that as well. The size of the workplace and the time between injury and the baseline interview. So there are some important differences around the claim submission and adjudication process, which differs between psychological injuries and musculoskeletal conditions. And so we took that into account in terms of our analytical models. So as I said, all these factors don't explain the differences I'm about to show you. So in terms of the personal factors, so now we're going to look at the relationship between injury type and these important predictors of return to work within these 4 different areas under the Wazil model. So in terms of the personal factors, you can see that musculoskeletal claimants with musculoskeletal conditions had less mental health symptoms, so higher scores on their self-reported mental health scale that we used. Although not a complete absence of symptoms among musculoskeletal conditions. In terms of recovery expectations, people with musculoskeletal conditions were more likely to have positive recovery expectations, although in general, recovery expectations were fairly high among both types of conditions. At the workplace level, people with musculoskeletal conditions were more likely to have a positive supervisor response. You can see only 36% of people with psychological conditions told us that their response was something that we could have coded as being positive. They were more likely, musculoskeletal conditions are more likely to have a positive co-worker response, more likely to have good return to work coordinator interactions, more likely to have a consultative return to work plan, with people with psychological conditions more likely to tell us they were not given a plan or any offer of modified duties. You can see 48% of the people with psychological conditions reported that they hadn't been given a plan and that there was no offer of modified duties. And we'll come back to this point in our discussion. In terms of the healthcare provider factors, people with musculoskeletal conditions are more likely to have been given a return to work date. Although contact with the workplace from the healthcare provider with either the workplace or an occupational health care provider at the workplace was similar. So of the 10 factors that we examined, 2 were similar, and this is one of them between psychological and musculoskeletal conditions. The second factor, which was similar, was this one about the claim manager doing all the required tasks. So this is the one where people said they were polite, that they treated them with respect, that they provided information, that they took their needs into account. You can see it's not as high as we might like. It's less than 50% for both types of conditions. But there was no difference across injury types in terms of saying that the claim manager did all of these things that would be required for them in terms of the return to work process. But in terms of the stress of those interactions, non-stressful interactions were much more common among musculoskeletal conditions compared to psychological conditions. So in terms of those key messages that I reported at the start of the presentation, the first key message is that inequalities exist across each of these 4 areas when it comes to psychological injuries compared to musculoskeletal conditions. And so we need to, as I said, out of the 10 factors that we examined, only 2 of them were not different between psychological conditions and musculoskeletal conditions. So there were differences at the workplace level, at the system level, at the personal level, and at the healthcare provider level. So in terms of examining return to work outcomes, so these are now adjusted for each of the different confounders that I presented earlier, and we can still see that there are strong differences in terms of sustained return to work across injury types. Differences at time 1 being in the range of 19% in terms of the differences in terms of sustained return to work, seeing differences of 13% at time 2, and smaller differences. I can hear someone's microphone. If people can just check if they're muted, that would be great. So we can see differences, they get smaller. So at time 3, we don't see a difference across injury type, but we can see quite strong differences at time 1 and at time 2. Now, in terms of trying to piece together the relationship between injury type, between these intermediate factors and return to work outcomes, we took a path modeling approach, which is where we can include multiple mediators in the model. We can examine the relationship between each of these different mediators. And also we can see how well the data supports the model that we've put in place. I'm not going to present today the model fit statistics, but I'm going to describe this path model and the relationship between injury type, all the different variables that I've described, and return to work outcomes, and how much of the differences you can see here that can be explained by the different factors that lead from injury type to the return to work outcomes. So if we think about, we've got psychological injury claims here on the left-hand side of the screen. We've got our return to work outcomes on the right-hand side of the screen. And what we did is we then built our path model by trying to, we built our path model describing the different types of factors in between type of injury and sustained return to work. So the first relationship was psychological injuries were less likely to have a positive supervisor response. In turn, people which had a more positive supervisor response were more likely to have good claim agent interactions, were more likely to have a consultative return to work plan or an offer of modified duties. Positive supervisor responses were also associated with better mental health symptoms, so an absence of symptoms, and more positive recovery expectations. There also was a separate relationship between psychological injury claims and having a consultative return to work plan, which was separate to the supervisor response. So there was a direct relationship between psychological injury claims and having a consultative return to work plan, and also with mental health symptoms. In turn, an absence of mental health symptoms and having a consultative return to work plan and an offer of modified duties were associated with a healthcare provider providing the claimant with a return to work date. And then there were 4 factors: mental health symptoms, healthcare provider return to work date, consultative return to work plan or an offer of modified duties, and non-stressful claim agent interactions that are associated with sustained return to work at time 1. Psychological injury claims, there was a remaining effect, which is not statistically significant, but after accounting for all these factors, people with psychological injury claims were less likely to have a sustained return to work at time 1. In terms of time 2, sustained return to work at time 1 was the best predictor if someone had a sustained return to work at time 2. In addition, mental health symptoms measured at a baseline interview and positive recovery expectations were also associated with sustained return to work at time 2. And then the only thing associated with sustained return to work at time 3 in this particular model is whether someone was back at work at time 2. So you can see that there's a less variability in terms of people moving on and off or in and out of sustained return to work between time 2 and time 3. One of the advantages of our path models is we can actually separate each of these different paths and work out how much of the difference in sustained return to work at time 1, for example, is accounted for by each of these different paths in our model. So focusing on mental health symptoms. So the path between mental health symptoms, we have a path between psychological injury claims, mental health symptoms and sustained return to work, and also a separate path through mental health symptoms through to return a healthcare provider return to work date and onto sustained return to work. And this explained about a third, just over a third of the total effect between psychological injuries and sustained return to work at time 1. In terms of the consultative return to work plan, so again, this has a direct relationship between having a psychological injury claim, not being offered a consultative return to work plan and modified duties, and then sustained return to work, as well as through the healthcare provider providing a return to work date. This explained about 30% of the total effect between psychological injuries and return to work at time 1. And then through a positive supervisor response, which has multiple paths, because the supervisor response was related to both mental health symptoms, consultative return to work plans, and good claims agent interactions. And through the positive supervisor response, this explains 13% of the total effect of psychological injury on return to work at time 1. And so together, each of these different paths explain about 2/3 of the difference in terms of that 19% difference in sustained return to work between psychological injuries and musculoskeletal conditions at time 1. So in terms of our second key message from today, so modifiable factors, the supervisor response, consultative return to work plans and Office of Modified Duties, and mental health symptoms explain about 2/3 of the difference in return to work between psychological injuries and musculoskeletal conditions, noting that that absolute difference, after taking into account the different confounders, was about 19% in terms of the prevalence difference. Most of future return to work at our second time period and our third time period was driven by whether someone had returned to work at this early time period. Not all of it, but a lot of it was determined by your current return to work. So in terms of looking at wage replacement, just to give you a sense of what it might look like among the psychological conditions which had a positive supervisor response and a consultative return to work plan, which is this bar here on the left-hand side of this slide, compared to those conditions where there wasn't a positive supervisor response or a consultative return to work plan. We compare that to musculoskeletal conditions with a positive supervisor response and a consultative return to work plan, compared to musculoskeletal conditions which don't have a positive supervisor response and a consultative return to work plan. You can actually see that the median, which is where these two bars meet, is about 9, both for the psychological injuries of the positive supervisor response and a consultative return to work plan, and for musculoskeletal conditions. A little bit more of a tail in the psychological injuries, but at the median, we see about 9 weeks of wage replacement, which is similar between both types of conditions. However, this type of situation only happens in 12% of our psychological claims, compared to 18% of the musculoskeletal conditions. It's also important to understand that a supervisor response and a consultative return to work plan doesn't occur in a vacuum. It's not like you could just say, well, let's start to make people more positive when people return or report psychological conditions, or we'll just put in place a consultative return to work plan. This is a figure from a paper which I was as an author on with some Australian colleagues, which talks about the integrated approach which is required for workplace mental health. We need to create environments in a workplace that don't lead to psychological injuries occurring in the first place, and actually focus on creating a work environment where we're promoting the positive aspects of work, rather than only focusing on trying to manage psychological injuries when they occur. And it would be no surprise to learn that the organisations or the context which is most likely to lead to a psychological injury is also the context where those injuries are not likely to be well managed. And so, in effect, the organisations that are the least well equipped to deal with returning people to work with psychological conditions are the organisations in which these conditions occur more often. And in relation to consultative return to work plans, certainly one of the things that we saw in our particular study was that workplaces really, when it comes to work-related mental health conditions, given the context of work that leads to these conditions occurring, trying to come up with modified duties and a return to work plan in those environments is very, very challenging. And often people were only told, well, you could just work fewer hours or fewer days, which wasn't really, which they didn't see as enabling them to actually return to work, because addressing mental health, work-related mental health conditions actually requires more structural changes in the work environment. And these are often harder to put in place than some things which you might consider around physical injuries, such as changing equipment or the way equipment's set up within the workplace. It's not as simple as that when it comes to psychological conditions. So a key message number 3, so differences in sustainable return to work can be modified. So before I'd shown that picture or the diagram where when we look at psychological injury claims that have had a positive supervisor response and report a consultative return to work plan with modified duties, they actually don't look very different to musculoskeletal conditions in which that's occurred as well. So based on our results from this cohort, while treating symptoms of mental health conditions remains important, we also, a workplace context that leads to a positive supervisor response and enables a return to work plan that's consultative is just as important in terms of improving return to work outcomes among these particular types of conditions. So just to acknowledge the various members of the research team, which were a variety of different organisations and institutions, funding from the Australian Research Council, a variety of different research partners and other organisations. If people want more information, the findings I presented today have been published in Social Psychiatry and Psychiatric Epidemiology. More information about the cohort is available in the publication in BMJ Open. And that is my final slide with my contact information if you don't have time to ask your question today or if a question comes up later. Thank you, Monique.
Thank you, Peter. Now, at some point, Peter, your camera seemed to go off. We're not seeing you anymore. I don't know if you're able.
Turned it off. I assumed it was maybe because my internet was.
Oh, there you are. Okay, you're back. Thank you. Thank you very much. That was a great presentation with an enormous amount of comprehensive data and addressing a really complex issue. So thank you. I just want to let everyone know again that if you joined later, Peter's slides and recording of the presentation will be available on the IW website in about a week or so. Occasionally people are having some difficulties hearing you, Peter, so if you can I don't know if you're able to turn up your volume for the questions, but I think for most of us it was okay. A number of questions have come in, and some of them actually touch on issues that I think you talked about later, so they came in earlier. So you may find that you don't need to answer them in as much depth, but I'm going to ask some of them anyway because I think that it's important for the messages to be clear to everyone. So the first person I think is really touching, or the first question came in quite early, and it touches on your third message, which is there much or any evidence that treating symptoms improves return to work outcomes?
So I think there's a couple of ways to answer that question. So we do know from the literature around, so certainly what we saw in our cohort was that symptoms are an important component. So greater symptoms of mental health were less, people which had greater symptoms of mental health conditions were less likely to return to work at our first time point and at our second time point. And so treating symptoms is an important part of it, but it's not the only part. So it was about a third, the relationship with another third explained by the supervisor response and the consultative return to work plan. I think one of the particular challenges, so we know from areas outside of work-related conditions that things like work-focused cognitive behavioural therapy has shown to be effective in terms of trying to get people to think differently about the work environment. But as I mentioned at the start, a lot of that has come from environments where it's not just work-related conditions. And so that's easier said than done in the work-related context. And I think that's so addressing the symptoms is one thing, but people aren't going to want to return to an environment which created the psychological injury in the first place.
Okay, thank you. Another question, someone is interested in whether your comments on whether this is really a like for like comparison, the mental health and the MSK, in that it seems to take an awful lot for an injury to be labeled as a mental health injury compared to, with chronic stress and the time that goes into that, whereas other conditions, even relatively minor conditions, seem to be recorded, even if there's just a day or two absence.
Yeah, so I think there are some particular challenges for psychological claims around how workers' compensation is set up. Some of the things we've noticed in Australia was even around where you have to put, well, what was the date? What was the date that the injury occurred? Well, if it's been gradually increasing over a period of time, coming up with a date can be quite challenging for people. There's an adjudication process as well, which tends to be a lot longer for psychological injuries in Australia as well. So there are some of these differences that tend to exist, and that's one of the reasons we accounted for the time between when the injury occurred or when the claim was submitted and when we were able to interview people within our cohort. We also know in the Australian context there are quite large differences between the acceptance rates. So we know that for a lot of psychological injuries, these tend to be rejected, more likely to be rejected at the start and then re-accepted after an appeal has been put in place. And so there are some differences. One of the reasons we focused on musculoskeletal conditions as our comparison group rather than non-psychological injuries is because often musculoskeletal conditions have a similar etiology around, sort of this gradual onset. It's hard to distinguish between, how much of this is work-related, how much of it occurs outside of work. And so that was one of the reasons we went for that comparison, as opposed to, say, a fracture, where it's quite clear. But yeah, have we accounted for everything? Well, no, but we do have a pretty good sense that the psychological injuries in our cohort are similar to the types of psychological injuries that are submitted to workers' compensation in Victoria.
Okay. Couple questions about your sample and whether it's representative and the findings are generalizable. Someone notes that the response rate was 36%. And so do you have some understanding of those individuals who didn't participate? And can you just speak a bit more about those issues?
Yes, we did do a comparison of the source population, which was anyone who met the inclusion criteria for musculoskeletal conditions or psychological injuries within the time when we were recruiting our cohort. We did find that men and people in, male-dominated industries were less likely to be recruited into our cohort, but there was actually no difference across the type of injuries and many of the other factors that we looked at. So I think the sample is generally representative of the types of compensation claims that got submitted, which would have met our criteria at that time point. We had some additional attrition that occurred over time, and that was dealt with in our analytical models using some maximum full information, maximum likelihood imputations in terms of the missing data over time. There's a broader question there, which is there other different selection processes into the workers' compensation system between psychological injuries and MSK conditions? And yeah, I think there are. Certainly there are in Victoria. I would imagine there are probably, we haven't looked at the data in Ontario or other Canadian jurisdictions, but I imagine there are across a number of jurisdictions just around, as again, when does the conditions work related? How do you go through the process? There's issues around stigma. There's issues around, belief, the process, the adjudication process. There are systems which are in place, which certainly in Canada, we've got systems which are in place which have traditionally dealt with these types of conditions, which now shouldn't be dealing with them. They should be going into workers' compensation, but it creates a challenge when you're used to submitting it through one system, but now you've got to submit it through a different one. So yeah, there are potential selection effects in any cohort, and I don't think ours is immune to those.
Okay, thank you. You made some comments about individuals with the organizations who often were dealing with mental health claims were often the worst prepared or ill prepared to be actually doing something about them. And so one of the questions relates to that in terms of whether there were particular industries, for example, healthcare, where they saw more mental health claims. Was that the case in your sample, or were they generally found across all sectors, broad sectors?
So we do find claims. I mean, there are certain types of industries where we see higher rates of mental health claims. Our particular study is not, we're concerned with sort of understanding the journey once the claim gets submitted, not in terms of the rates of claims, but we do see the claims are more likely to be submitted among healthcare occupations, among service-related occupations, among education types of occupations as well. I mean, in general, if you think about it from the claim perspective, so we know that there are certain types of psychosocial factors that are related to the development of work-related psychological conditions. So these are things such as unrealistic deadlines, bullying, harassment, job autonomy is also related to these types of conditions. So these types of cultures which lead to these things, I mean, they're harder to address. So these claims are sort of brought in from a workplace context, and then really in order to accommodate these types of conditions, you need to change the workplace context. And I think that's what I was trying to get at, where I was sort of saying that the environments that create these conditions are actually work against in terms of trying to return to work in those types of things. They're often jobs where you have to return and find that you have to be working at 100% of your mental capacity to re-enter that type of occupation, given the tight deadlines and the high stress and the bullying. And so what we did find in our cohort was that when psychological injuries returned to work, they actually did report virtually no presenteeism compared to musculoskeletal conditions, which could return at a point where they were still trying to manage their condition. So it was for the psychological conditions, they had to, the condition had to be resolved before they could return to these types of environments, just given the work context in those environments to begin with.
Okay. Did you find any gender differences? MSK conditions in women and sometimes mental health conditions may be underreported by gender. Did you find, or were you able to look at any differences?
So we do have, not in this particular study, we do actually have a paper which we're currently is in preparation, where we're actually looking at things such as yes, I agree that there are gender differences, and in particular around the recovery. So people having to balance recovery with household responsibilities is something which we know prolongs time off work among musculoskeletal conditions. As I've sort of said in the past, work-related psychological injuries, we don't have a lot of information on the context in which that occurs, but we do have a paper underway where we did ask people about household responsibilities, around the gender composition of the work environment, around different other roles and expectations which are gendered. And we do plan to better understand how sex or gender in terms of our cohort is related to each of these different factors, and how those things are related to return to work outcomes. So for this study, no, but it is something which we've got our eye on for some future studies.
Okay, a couple of questions about modified job duties. And I don't know if you have some thoughts about what organizations do when modified job duties are really limited in terms of someone has a very specific job, like a public-facing job, or it's difficult to find something for them. Do you, based on these findings or other work, have some comments about the challenges there?
Yeah, so certainly I think it's a real area where we do need more work about what are the types of modified duties that are successful. And again, I'm going to re-emphasize this point, for work-related psychological conditions. A lot of what we know is from general samples where conditions can be work-related and non-work-related. And I think trying to change the work environment for a work-related condition is different to changing the work environment and the perceptions of for a non-work-related condition. One of the things we did, which came out very clearly in our study, was that the things that were offered to people with psychological injuries were one of two things: working less hours or working fewer days. And that was all that was offered. And often that, again, is sort of seen as, they don't feel like they're contributing, their co-workers don't feel like they're contributing. But really the structural things that need to be put in place are much harder to deal with. So, for example, if you've got a work environment where there's a culture of bullying and harassment with unrealistic deadlines, to try and address that is what's required to help people return to work. But that's a huge change in an organisation to change the culture. But really, if we're going to be effective in helping people return to environments, that has to happen. And often in our cohort, we found that people with psychological injuries said that they didn't want to, or their healthcare provider didn't want them to go back to the work environment because nothing had been changed, and it was highly likely that the condition would reoccur.
Okay, so lots of comments coming in, by the way, Peter, that this was an excellent presentation. So while you catch your breath and I read the next question, I just wanted to let you know that. A question about disputed claims, either disputed by the employer or by the compensation board. How did you take that variable into consideration, or does your sample include disputed claims? And if not, do you have plans to look at this as a variable that can affect return to work?
Yeah, so the disputed claims is an area that, so we took it into account around the time factor, and we did find that, as I said, well, not a majority, but in terms of the claims where we tended to recruit people quite a long time after the injury occurred, these tended to be much more psychological than musculoskeletal, because there was either an initial rejection of the claim, which was then re-accepted. We do know in the Victorian context, and again, I don't know, we don't have a lot of information in the Ontario or the Canadian context around what's happening with psychological claims. In the Victorian context, we know that about half of the psychological injury claims that are submitted get an independent medical examination on submission within the first 30 days of submission. So that gives you a sense of, that's not a great way to start the compensation process, which is, I don't believe what your doctor said. We want an independent assessment of whether this is a psychological condition or not. So I think there is, that's an underlying factor. We only looked at accepted claims. I think it would be a really interesting study to look at anyone who submitted a claim and then what happens to people who aren't part of the compensation system. Are they better off or worse off? And I think, given certainly the acceptance rates in Victoria, there would be enough people to conduct a study on that. It's just hard in terms of recruiting them to find them. But so I guess to summarise, we took it into account a little bit, but there's a lot more in terms of the selection process that's going on, and it would require a different study to understand what happens to people who can't get workers' compensation for these types of injuries.
Okay. Someone comments that they've been involved in with a number of organizations looking at return to work, and that many organizations believe they are consultative in their return to work processes, but that they really aren't. And wondered about your views on the role of the organization, and really, do we need possibly some of these reviews on the consultative nature of return to work to be conducted by people who are outside of the organization?
Yeah, I think consultative means getting everyone together, like listening to the worker, listening to what their healthcare provider thinks, either through the worker or directly with the healthcare provider. Thinking about, one of the big things is about thinking about what are the types of activities that you could do, regardless of whether you were doing them before. What are the types of things you could do, given your condition, given that, I think if you start with the point that most people, the majority, if not all, people want to actually return to work. They've had this condition, it's work-related, they've had to take time off. Most people want to return to work. Work, if we can promote the positive aspects of work, work's a really beneficial thing for people. People enjoy going to work and doing stuff. And I often think workers, given that they know their condition, they've talked to the healthcare provider, they've got a good understanding of what things trigger this condition, what things don't. They can actually often come up with solutions in a collaborative way with the organisation. And so, and I do think it's it's not one of these things where I don't think there's a one size fits all, but there's probably hallmarks of good approaches that work. And I think we need to better understand, especially now that these claims will be increasing in all jurisdictions, now that most jurisdictions are accepting these as workers' compensation. We need to better understand, how do we put in place systems and procedures that enable people to have modified duties that are meaningful, and a return to work plan where they feel like they've had their opinions heard.
Okay. Peter, I know you had some references to some of your slides. Someone is asking whether you could put up the slide with some of the references to the published work while you're answering some of your other questions here. We'll keep going until we run out of time. And again, please contact Peter if your question doesn't get answered. A question for you, Peter, about the tools that are used to assess expectations of recovery for psych claims. Are there a lot of tools out there? Are there consistent ways people are measuring this concept? And can you just comment on that?
Yeah, so I don't know a lot in terms of, so what the tool which we used, which is not directly related to recovery, but it's around when people had returned to work, we asked them about, the amount of time that they could do certain activities, which was sort of it's a scale of presentism around limitations they might have in terms of the work. So when using that tool, we found that people who had returned with psychological conditions had higher levels of productivity than people with musculoskeletal conditions who could return at a lower level of function into the workplace. I think in terms of trying to understand around impairment, around psychological conditions, that's another interesting area where I do think we need to have more information about what are the measures of impairment that are currently available. How can we determine when someone can return to work? And again, even these simple questions about trying to think about, well, what can people do? Like, how can we talk not just about what should they avoid, but what could they do which would enable them to return to work? So I don't have a clean answer again to that question, but I do think we need to better understand around, when are people ready to return? And I think, again, given that these conditions, musculoskeletal conditions as well, but certainly around psychological conditions are quite episodic in nature, we do need, it's not a matter of like sort of providing the offer of accommodation and the modified duties, but it's about constantly rechecking, as in, is this still working? Could we increase some things? Could we reduce some things? Because it will be episodic in terms of when, good days, good weeks, bad weeks, as people return to the workplace.
Okay. Given that so much of what your messages were revolved around modifiable work factors, this is not all about the individual, but it is also about that broader workplace environment. You talked about supervisor responses, a consultative return to work support, collaboration with treatment providers. What would be your recommendations for next steps for organizations? What should they do, having heard your presentation today?
Well, so I do think, one, we need to think about, can we use the same approach for work-related psychological injuries as we do for a non-work-related condition? I don't have a definitive answer on that because we haven't had enough studies where we've collected both types of injuries. If I had to generate a hypothesis, I would say that there are certain aspects based on what we know from physical injury. So there have been some studies in New Zealand that have looked at the return to work process for physical conditions that's work-related versus a physical condition that's not, because they've got an all-encompassing system, and they find that there are different factors that are at play. So I think we need to understand what are the key differences and how do we address those. I do think now that we've got a better recognition that work plays a role both in the generation of a certain proportion of psychological conditions and in the return to work, we do need to better understand, well, how can we modify the environment? So, I'm sure there are companies that are currently working there which actually think they do a pretty good job, or providers who work as consultants to companies who think that they've got a system that works. So I think we do need to start to see and hear those stories, so that, because I feel like in our cohort, I would imagine that it's not that workplaces generally didn't want people to return to work or were making it challenging. It's that often they just didn't know what to do to help people return to work in a way that would be safe. And so I think that's, again, the key. So we do need much more information. I think we need to, as I said, potentially look at work-related conditions as a subcomponent of all types of psychological conditions in return to work.
So maybe two more questions, Peter. See how you This is terrific. Do you have any data where you had people with both types of injuries? So for example, someone who sustained an MSK injury as a result of perhaps violence in the workplace. So there'd be a mental health component as well. Can you talk about that in your data and whether that is an important aspect of working in the future?
Yeah, so we did. So for people who had multiple types of injuries, so for example, someone who had a fracture as well as a musculoskeletal condition, or both types were on their claim form, we did exclude those because we wanted the comparison between the psych and the musculoskeletal condition. Over the course of our cohort, one of the interesting things is the mental health profile of the two injury types, while it was quite different at the start in terms of the K6, which is what we used to assess the symptoms, by the time we got to our third time point, psychological conditions and musculoskeletal conditions looked almost identical in terms of the mental health symptoms. And that wasn't because necessarily musculoskeletal conditions the mental health symptoms had increased over time. It was that they remained stable. And we do know from other work on this cohort and also cohorts in Ontario that there is a reasonably large proportion of people with musculoskeletal conditions which will have a comorbid mental health condition that will develop over time as potentially as part of the compensation and return to work process. So I guess I would say that we excluded them at the start, so we didn't have people with multiple conditions at the start, but it is interesting how by the time, over time, the mental health components of psychological and musculoskeletal injuries actually become much more similar at about 10 to 15 months out than you would think.
Okay. Do you have plans to try to replicate this study or do a similar kind of study with data from Ontario?
I think it would be, I think there are key questions that need to be answered in the Ontario context around psychological conditions now that they've been accepted by the Workers' Compensation Agency and in other provinces as well, such as British Columbia. I always have plans to do more research. It's a matter of, I guess, these types of projects require really tight coordination between the Workers' Compensation Authority and the research team, just in terms of how we recruit people at the moment. At the moment, we have our one study which we're currently doing in collaboration with the Workers' Safety and Insurance Board around the long-term outcomes. But certainly, as we finish that study, I do think it's important to understand and look at this in the Canadian context to better understand, do we see the same differences between psychological injuries and musculoskeletal conditions, or do we see differences? So, yeah, I think we have plans, but we don't have anything currently underway to replicate this study.
Okay, I'm conscious of the time. So Peter, lots of comments about this being a great presentation. I just want to echo those comments. Thank you so much for all these data, and thank you all for joining us. This has been terrific. We've had a lot of great questions. Again, if you didn't get your question answered, there is more information in the studies that Peter cited, and you can contact him directly with your questions. And I would like to invite all of you to come back and join us next month on May 11th, when our next speaker series will be by Dr. Abby Biswas, who will talk about the health paradox of physically demanding work. What is it, and should we be concerned? So thank you again, Peter, and have a wonderful day, everyone. Take care.
Thank you. Bye-bye.
Bye-bye.